with opiate addiction or alcoholism, and everybody but one raised their hand. And when I explained that part of him, he said, oh yeah, my mom has fibromyalgia. Okay. And a lot of times you'll see that your parents will be on chronic opiates. They may have chronic pain issues and be on chronic opiates for a long period of time. That's the same disease. With the term addiction, you only cross that line when you wind up in trouble because of taking opiates, okay? And that's why the term is really such a terrible term. That's kind of like waiting to diagnose diabetes when you've had both your legs amputated and you're on dialysis. That's a little late to make the diagnosis, okay? We should be making this diagnosis a lot sooner. Talking back about that 24-year-old woman, after 2 months getting treatment for her broken leg, her orthopedic doctor fired her and said, you're a drug addict, okay? She was not a drug addict until the moment he fired her, because then she had to go to the street and buy it illegally, okay? The diagnosis in the DSM-5 is a dysfunctional result in your life from taking opiates. I mean, I've got quite a few patients who, well, I'll give you an example. I've got one patient who took his first Lortab when he was 16. He was in high school, okay? He came to see me 10 years later. I asked him what's the longest period of time he went without taking anything after he took that first painkiller. He said, what do you mean? I've taken Lortab or Percocet every single day of my life since I took my first painkiller. He said, that first painkiller changed my life. He said, it's the first day I ever felt normal in my whole life. He said he would walk down the hallways at school and see people smiling, and he thought they were just full of shit. That's what he told me, okay? So he came to see me 10 years later, and he'd never had any legal problems, never had any financial problems, never had any relationship problems. So he wouldn't even meet the diagnosis of addiction, all right? He showed up for his first appointment driving a Mercedes. And I've got quite a few patients like that. They wouldn't meet the criteria for addiction, yet they've got the exact same disease, okay? We've got to start catching this before people wind up going to jail, overdosing, losing their kids. Okay, again, we're making this diagnosis much too late. Now, who makes the diagnosis of high blood pressure or diabetes? Doctors do, right? Who makes the diagnosis of addiction? The patient does. People show up on our doorstep here saying, I'm an addict, I need treatment, okay? If a person who had diabetes had to wait to diagnose their own diabetes, they would be dead. Okay? The orthopedic doctor, if he had been trained and knew what was happening, he could have said to that woman, even after she brought the empty pill bottle back 3 days later, said, oh, okay, I know what's going on here. You have this disorder. We need to get you to someone who can care for you. Okay? Now, people... I mean, everybody's heard a lot of things, you know, out in the community, like, well, you're just substituting one drug for another and stuff like that. Have you all heard that when you're talking about Suboxone? Is there any other disease in all the practice of medicine you can think of that it is not okay to treat with a medication? No, there's not. So now that we have a medication that can actually treat this disease, nobody wants us to use it, right? Now, the thing you have to understand about Suboxone, there's no cognitive impairment. You're not stoned when you're on it. You're not drunk. Causes no liver or kidney problems. It's overdose proof. It takes 5,000 pills all at once to kill you. It's overdose proof. It's safer than Tylenol in essence. You can't overdose from it. Fewer people die from buprenorphine than die from Tylenol in the United States every year. So it's a very safe, effective medication, yet people don't want us to use it. Very, very frustrating. So does all that make sense so far? Okay, I'll say one other thing about the substituting one drug for another. Everybody here has heard of schizophrenia, I imagine. Now, if a schizophrenic is not on their schizophrenia medicine, they will shoot heroin, they will drink, they will smoke pot, they'll take whatever they can to try to stop the noise in their head. But once you put them on schizophrenia medicine, they stop all the rest of it. It's the appropriate medication to treat the disease. Now, in all the patients that I've put on buprenorphine over the years, the vast majority of them tell me that when they're taking Suboxone, they don't crave anything else at all. They don't want any other opiates. They just feel normal. They just want to live their life. Okay. The other interesting things about Suboxone is that it has a ceiling effect, which means after you're taking 2 or 3 a day, if you take the rest of the bottle, you'll have no more effect. and it blocks the receptors from any other opiate getting to it. There's actually cases in the literature where people have overdosed on heroin and somebody gave them a Suboxone and it reversed it and woke them up. And that's actually something I think that everybody needs to know. You know, there's a lot of talk in the community about having Narcan available to reverse overdoses. A Suboxone will reverse an overdose. And there's a whole lot more Suboxone out there than there are Narcan kits. You know, and chances are if somebody's in a crowd of people that they overdose, there's probably somebody else in that group who's in treatment. But it's just something to keep in mind. Okay, so any questions about that? There's one other thing that I don't usually mention, but I'm going to mention it today. The fourth symptom is agoraphobia. I don't know how you spell that. I think that's the name. Which is not liking to be in crowds. Okay, and somebody that I saw today mentioned earlier that they just don't like to be in crowds. Okay, and that's part of this disease also. Okay, so those are the signs and symptoms, and that's the pathophysiology. All right. Now you all now know more than 99.9% of doctors know about the disease of addiction, even people who are writing Suboxone. Okay. The frustrating thing is that they are getting no education on addiction in medical school and residency still. Okay. Went to 4 years of medical school, 3 years of residency, didn't get a single lecture on addiction. Now you got to remember that 10% of all people at some point in their life will have a substance use disorder. That's the same percentage of people who have diabetes. I got thousands of hours of education on diabetes and not a single lecture on addiction. We actually are associated with university. As I said, I'm an assistant clinical professor, and we have medical students who rotate through here with us. But this is an elective. It's not even a required rotation for medical students. And there's no training for residents. So it's still a little frustrating. But that's why you all have to know about your disease. Okay, as I mentioned to somebody earlier today, you know, there's what I call high maintenance diseases and low maintenance diseases. A low maintenance disease is like appendicitis. If you get appendicitis, you go, you have your appendix out and you're done. You don't need to know anything about appendicitis. A high maintenance disease is diabetes. You have to know how to check your blood sugar, how to drop the right amount of insulin so you don't overdose and kill yourself. You have to be a dietitian. You have to know a lot about your disease to take care of yourself. It's the same with addiction. You have to know about your disease because other people don't. Okay? Now we have a lot of literature. Everything that I tell you is based on scientific studies and literature, okay? So it's not just opinions. So if you've got questions about any of this, I've got information that I can give you, some literature to kind of help with that. Now there's a couple other things that I think is important to know. Now people are not either 7s or 1s. People live all according to this spectrum, okay? Now it turns out that half the people who suffer from a substance use disorder in their life will get better on their own. So only half of those need treatment. Well, which half do you think it is? Why do you think it's half of those people get better and half don't? It's because this is half the people and this is half the people. If you live here, Percocet will make you feel some better, but you can still function without it. You may not be the happiest person on the block, but you can still function, okay? Now part of the problem is you get people like this who get clean in an abstinence-based program and become a counselor. And then you have somebody like this who comes in and they can't do it abstinence-based only. And this person says to this person, well, I did it without any medication, why can't you? And that's some of the most serious damage done to people. These are different diseases. This disease is different from this disease. It's, again, like type 2 diabetes. Some people with type 2 diabetes, if they eat right, exercise, lose weight, they can come off their medication. But some people, no matter how hard they try, no matter how well they do, their blood sugar is still 500. It's a different disease, okay? So these are very different diseases. And you can't use the one-size-fits-all approach to everybody. Now, people who are just genetic addicts, and this is a genetic problem, just like type 2 diabetes, people who are just genetic addicts just need their medication like they need blood pressure medicine, and that's all they need. They don't need groups, they don't need counseling, they don't need anything else but the medication to make them perfectly normal. Like the guy that I was talking to you about earlier. I've been seeing him for about 10 years now, and all he needs is his medicine. I mean, on the first day that I met him, I knew he would never fail a drug screen, and he hasn't, because all he needs is his medicine. Once he's taken his medicine, his brain functions perfectly normally. He doesn't crave any other drugs, and he does fine, okay? But just like diabetes, there are two different types of issues with addiction, two different causes of addiction. This is that big stack, isn't it? These are handouts that I give to everybody on their first visit. It's got some information here. The first article is called Understanding Addiction. I've got a couple more over here. And it's just kind of a rehash of what I've just been talking about. And the next in here is a brief overview of Suboxone and the treatment of addiction. And I'm going to keep one of them.
I can give you some last time.
Oh, okay. And actually, I think some of these handouts might have different things in them to kind of cobble them together. So the first one is Understanding Addiction. The next one is a brief overview of Suboxone and the treatment of addiction, which kind of explains how Suboxone works, just like I did, just briefly, and what the experts say on the subject. Then I've got one in there, the myth of tapering. Okay, now whenever you hear someone use the word addiction in a sentence, I want you to substitute the word diabetes and see if it makes sense. We're going to taper you off your diabetes medicine, and your diabetes is going to go away. Does that make sense? Is there any other disease that we taper people off their medication? Let's say Eeyore here, we put Eeyore on Prozac, and he feels good. When are we going to take Eeyore off his Prozac? Never. I worked with a master's level counselor for a while who had been on Prozac 21 years. Every so often I joke with her, I'd say, when are you going to come off that shit? And she'd kind of go, arr. But the other thing is, let's say Eeyore's depressed and we put him on 20 milligrams of Prozac and he feels some better, okay? Well, if he's still somewhat depressed, what are we going to do? We're going to put him on 40 milligrams of Prozac. What is it that they try to do with Suboxone? They always try to taper you down and get you on the lowest possible dose, okay? Now, the reason for that is because with regular opiates, you develop tolerance, right? So you put somebody on Percocet, and after a while, it doesn't work quite as well. So you got to increase the dose, it doesn't work quite as well. You got to increase the dose. Another neat thing about Suboxone is whatever it does to you on the first day you take it, it will never change. You never develop tolerance. So the idea is not to get you to eke by with the least you can get by with. The idea is to get you to where you feel normal, okay? Now, statistically across the United States, about 40% of people in treatment fail drug screens for opiates, all right? Our failure rate for opiates in our drug screens are essentially zero because we put people on what works best. Like the people that I've already seen today, I've asked you, where do you feel the best, okay? I went to an American Society of Addiction Medicine conference a couple of years ago, and that's one of the things that one of the guys was teaching. He said, I saw a patient who was on 8 milligrams, came to see me, and she was doing okay, but she wasn't doing well at work, her relationship wasn't doing well, and he talked to her, and she was depressed. He said, I don't think you're on enough medicine, so we bumped her up to, I guess, 2 a day. She started doing a whole lot better, okay? So what matters now with buprenorphine, or Suboxone, is to try to get people where they feel the best, not where they're eking by on the least amount of medication possible, okay? So it's a very different approach. I mean, it's the same thing that we do with other forms of depression, but you gotta remember the primary problem with addiction is it's a form of very severe depression. But it's really worse than just regular depression because people who suffer from this illness have no energy at all either. It's a lot more like low thyroid, okay? No energy, depression, all of that, okay? Okay, so far so good. Now, I'm going to have to reach in my briefcase here because my copy doesn't have this. Now, let's talk about the second cause of addiction. There is a page in there that's got a bunch of yellow all over it. Close, should be close to the back. It says the origins of addiction at the top. This is called the Adverse Childhood Experiences Study. This was a study that was done